It's my pleasure to now introduce our final clinical lecturer this morning, and that session will be brought to us by Dr. Arthur Baker. Dr. Arthur M. Baker III is a professor of obstetrics and gynecology at Mercer University School of Medicine and a board-certified specialist in maternal-fetal medicine. He earned his Bachelor of Science in Biology with magna cum laude honors from the Citadel and completed his medical degree at the Medical University of South Carolina. Dr. Baker went on to complete both his residency and fellowship in obstetrics and gynecology and maternal-fetal medicine at the University of North Carolina at Chapel Hill. With active hospital appointments at Memorial University Medical Center and St. Joseph's Candler Hospital in Savannah, Georgia, he has become a trusted leader in high-risk obstetrics in the region. Let's welcome Dr. Arthur M. Baker III to discuss management of the short cervix and evidence-based update.
Ooh, that's bright. Can y'all hear me okay? Great. Thank you so much for the warm introduction. It's a pleasure to be with y'all today. It's also daunting to follow some of the speakers. I was watching Hayward Brown yesterday and remembering when he interviewed me for a residency position at Duke. I don't see him here, which is probably good because I went to Chapel Hill and he'd probably give me a hard time in the question segment. But it's a pleasure to be with you this morning to talk about a topic that I think is important, perhaps a little bit more niche than some of the other lectures, but important nonetheless at expanding our efforts to prevent preterm births, not just in Georgia, but across the United States and the world. One little point of personal privilege, and then I'll get into the good stuff. How many residents are here or fellows? Raise your hands, come on. Okay. I wanted to give a round of applause to all of our program directors, assistant program directors, the people that really are working hard to develop the next generation. If we could give them a round of applause. All right. No financial interests. Maybe one day, but not right now. So the objectives for this talk are to identify patients who should get cervical length screening, to talk about the different scenarios when you may offer a cerclage or consider one in a patient with a short cervix. And then there's some alternatives, some of which are promising, some maybe not so, but all are being actively studied and add to the growing body of evidence of how we manage this very common obstetric complication. Okay. The definitions are important. A short cervix has traditionally been defined as a cervical length less than 25 millimeters, typically with some effacement or funneling, but no dilation of the external os or exposed membranes on a physical exam. And here's kind of a transvaginal image where you can see the external os here, the internal os, cervical canal. So a nice long cervix there. Wish we saw that every time. And this is an example, or relatively extreme one, of a transvaginal cervical length with a large U-shaped funnel. The fetus is here, and a very short cervix. Part of what is the standard if you're screening, especially vaginally, is to apply some gentle fundal pressure, because you can certainly be fooled. As in this picture, it looks like a relatively normal cervix, but with some gentle fundal pressure, it opens up and is quite short. Now, this talk won't address this problem because it represents the most extreme form of cervical shortening, where it's not just short, it is open with exposed membranes. That's sort of another lecture, but we do see this far too often, and perhaps with screening the appropriate people who should get a cervical length measurement, we could avoid this outcome. I talk to the residents a little bit about this from time to time. Is a short cervix the same as cervical insufficiency? I would argue it's not. A short cervix is just a cervix that's short. Cervical insufficiency is a little bit different. It's traditionally associated with people who have had painless dilation, mid-pregnancy losses, historically based on the presence of painless cervical dilation. Some of these people present with PPROM 20 weeks when they'd been had exposed membranes for days or even weeks leading up to that event. But nonetheless, these are the patients we try to identify before they even get to a cervical length screening to see if they're an appropriate candidate for a prophylactic cerclage. Some of the causes, trauma, aggressive cones or LEEP biopsies, sometimes overdilation of the cervix, maybe a cervical laceration during a difficult birth that then leads to a weak cervix in the subsequent pregnancy. The cervix should remain stable for the first 2 trimesters. I tell patients who have this complication in my office, your body's not supposed to prepare for the birth until the end, and the way it does that is the cervix softens, it shortens in the last few weeks to prepare for labor. But for some people, it happens way too soon, and really good evidence shows that mid-pregnancy cervical links correlate really well with preterm birth risk. A lot of the papers and evidence I'm going to present are from the last 25 years, specifically from about 99 to 2000, 2015, when there was a lot of really good, important landmark studies published addressing this topic. Dr. Bergella's name pops up a lot. He's on quite a few publications on cervical link screening and was one of my oral board examiners when I sat for my maternal fetal medicine boards. So no nerves there when I walked into the room. But he was the author, lead author on a paper about 25 years ago that looked at this, and they followed women with a prior preterm birth, and they did mid-pregnancy cervical links, associating it with preterm birth. So if you had a prior preterm birth in this study and a short cervix, just about a third delivered early. If you didn't, you still delivered preterm some of the time, but at a far lower rate. So that was important information. And that led to the concept of cervical link screening, where women who have had a prior preterm birth or a mid-pregnancy loss should really all get cervical link screening. I don't think that's controversial. It's typically performed between 16 and 24 weeks, depending on your level of concern. Measuring it bi-weekly or every week, depending on the situation, would be reasonable. Between 16 and 24 weeks, because this is the critical window in gestation where we have interventions that may reduce the risk for a preterm birth. Women who've had recurrent pregnancy loss or first trimester losses, there's really no role to screen them. Some of the older data surrounding cervical link screening for LEEPs or cones initially showed a strong association with preterm birth. Some of the more contemporary data shows maybe it's more just the presence of the HPV virus rather than the actual LEEP. But nonetheless, all of these people are reasonable candidates for cervical link screening. So what do you do when you see this? We see it all too often, short cervix. Should you offer cerclage? In this picture, you can see the knot or the stitch from here to here. And there's been a couple studies. One of the ones I love to tell the residents about because it's fascinating to me that a study with so few patients made a big impact. But it was the start of more studies that followed it. But this study in particular, the CIPRAC trial, which was presented at the 2001 Society for Maternal Fetal Medicine annual meeting, was a randomized trial of women with short cervix and risk factors for preterm birth. The big risk factor was a prior preterm birth. They included a couple other people that didn't have a preterm birth but had risk factors like multiple excisional procedures on their cervix. So maybe not the cleanest RCT, but it found a pretty big difference. So those women with a short cervix and major risk factors for preterm birth, in this study, and there was 19 of them that got a McDonald cerclage, none of them delivered before 34 weeks. But almost half the women who did not get a cerclage with a short cervix and these risk factors did. This is where it gets kind of fun because a lot of these studies I got to watch get presented. And so for the learners, the residents, and the fellows, and I see one of my co-fellows back there. Hey, Dr. Woodham. This study in particular, I think was presented when I was a first-year fellow. But it was a arguably better study than the first, but it was a multi-center randomized controlled trial of cerclage in high-risk women, prior preterm birth less than 34 weeks. So they all had to have that. And then they were screened with cervical links mid-pregnancy. The primary outcome was delivery less than 35 weeks. What's interesting about this, and what I would love for you to keep a close eye on, I know it's close to lunch, but they screened 1,000 women, high risk for preterm birth. A third of them had a short cervix in this study. That's a lot. They were randomized to cerclage or no cerclage. And it was like many studies, when the primary outcome for the study is negative, you go to some secondary outcomes. But it technically was a negative study. The cerclage group, 32% delivered preterm, 42% no cerclage. So there was a trend, but it wasn't statistically significant. And the cutoff was less than 25. So as a secondary analysis in the study, they stratified it to those women with a short cervix less than 15 and those 16 to 24. And for those women with a particularly short cervix and a prior preterm birth, they did notice a significant benefit there. Alternatives. So some patients don't want to go to the operating room, or some of them aren't appropriate candidates for cerclage. So other things that have been looked at and have been published quite a bit on is vaginal progesterone and bed rest. This was a great study that got published towards the end of my residency, but it was a large randomized trial, multi-country, multi-center, RCT, of looking at universal screening. So this was all comers, low risk, high risk, much more applicable to the patient populations that most of you see. And they screened 25,000 women. And if you had your cervix measured 15 or less, and you agreed to be randomized, you were put into a progesterone group, 200 milligrams daily vaginally, or placebo. Now what's interesting on this is, so this is a universal population, you still picked up about 2% of women with short cervixes. So the high-risk population, at least in that study that I showed you before, 30%. But if you just take a universal population, at least in this study of 25,000 women, about 2% of them will have a particularly short cervix. You can see that they were in their late 20s. Just over half, it was their first pregnancy. They were primogravids. 10, 15% did have a prior preterm birth. This was the average cervical length. A little later than I would say I see in my practice for the gestational age at randomization, 23 to 24 weeks. And they found that the relative risk was 0.56, so quite a big reduction with a very significant p-value. Basically cut your risk almost in half, at least in this fairly well-done study. A couple years later, towards the end of my fellowship, this study got published. Another well-done RCT of vaginal progesterone suppositories in women with a cervical length of 10 to 20 millimeters, around 19 to 24 weeks. The primary outcome was a spontaneous preterm birth less than 33 weeks. And what's interesting, again, they screened 32,000 women. They got about 2% too. So that's why I keep pointing that out. Every population is different, but these were fairly diverse populations based on risk factors, ethnicity. So I always tell as we get to the argument for universal screening, that 2% number I just want you to remember. But of the women with a short cervix in this study, half got randomized to 90 milligrams of a progesterone gel, and the other half placebo. Pretty similar to the other study. Mid-late 20s, just over half were primogravids. 10, 15% did have a prior preterm birth because this is a universal population. We're not selecting out for certain risk factors. We're including everybody, so it's more applicable to a general practice. Average cervical length measurement, 17, randomized around 22 weeks. So pretty similar studies. And pretty similar outcome. They also, in this study, had a statistically significant difference of about a 50% reduction in the rate of preterm birth less than 33 weeks. Which brings me to this topic. So based on this data, cerclage data, progesterone data, and there's so many studies, you can't present them all, so I'm trying to focus on some of the landmark ones. Does this fulfill all the criteria for an effective screening test? I would argue it does. It's relatively cost effective. The number needed to treat based on certain analyses is about 1 in 350 cervical lengths to prevent one preterm birth under less than 33 weeks. You'd have to do about 1,000 PAPs and colposcopies to prevent a death from cervical cancer. And so many academic centers have adopted some form of universal screening, certainly not all. In our practice in Savannah, we do universal screening transabdominally, and there's some studies that have relative good correlations between that and transvaginal cervical length screening. I have some places, or I'm sure you all know some places that do universal transvaginal cervical length screening, which has its own pitfalls because some patients are not going to want that type of invasive ultrasound. You have to clean the probes. You have to make sure your sonographers are well trained at identifying those cervixes. But in our office, we have a very low threshold to do a transvaginal exam. So if we suspect that there's any shortening or it looks like there's some funneling on a transabdominal image, we usually recommend to the patient that day that they go ahead and get a transcervical exam, transvaginal exam. What does SMFM and ACOG say? Well, kind of wishy-washy, but that's okay. We'll give them a pass. They say that for women without a prior preterm birth, with a preterm birth, they recommend for sure. Without a prior preterm birth, it's not officially recommended, but you can consider it. How nice of them. So I think it's a very reasonable thing to do. I think it's, based on your patient population, whether you want to be more aggressive and do transvaginal versus transabdominal. But I think some screening is probably warranted based on the 2%-ish chance that you'll find a cervix in all comers. That's not a small number, especially when we have some reasonably effective strategies to help them stay pregnant longer. What about bed rest? Oh boy. Well, what about it? We certainly, for years, decades, have thought that some activity restriction in high-risk pregnancy could be of some benefit. Intuitively, it makes sense. It does make sense. And anecdotally, you'll have patients, physicians who have good experiences implementing bed rest for some of their patients that are high risk. But what does the data say? Admittedly, this is a hard thing to study because how do you monitor compliance? How do you make sure the person who's on the no restriction group is actually not doing the things that, or is actually following those guidelines, and the people who are on bed rest and pelvic rest are really doing that. So it's a difficult study to do. Obviously, you can't blind anyone. You know what group you're in. But this was a great study that was published in the Green Journal just over 10 years ago. And it looked at about 650 nulliparous women that had a short cervix. And they were put into two groups, pelvic and bed rest, and no restrictions. And one of my favorite questions to ask of the residents, and I won't pick on any of them, I promise, is do you think that they found a significant difference between these groups in the preterm birth risk? And most of the younger ones were like, well, no, because you're setting us up that this is not going to work. And I'm like, no, there was a difference in this study. There was a difference. There was a 3 times higher likelihood that you deliver preterm if you're on bed rest and pelvic rest. With an odds ratio of about 3, a very significant p-value, and that was true for the very early preterm births too. It was less than 37, but even at less than 34, your odds were over double. So that was a little bit of a surprise to a lot of people, because intuitively it doesn't make sense. And we'll get to why maybe our intuition is wrong. This is another study, and there's a couple. There's admittedly not a lot of well-done studies on this because it is hard to study. But this was a study of 300 women with a short cervix. And this was kind of different. They didn't do bed rest or no restrictions. It was more engaging in some form of exercise. And to be fair, it's not marathon training, but get out there, enjoy your life, walk, get some sunshine, versus don't do those things. And they also had the same outcome, preterm birth less than 37 weeks. So it was a negative study. The odds ratio is 0.665, but the confidence intervals cross 1. But if you'll notice, the exercise group did trend better. They had 22% preterm births, whereas the other group had 33%. So I'm not saying exercise prevents preterm birth, but it does, in my opinion, again, it's a negative study on a topic that's admittedly not well studied. If you have not read this commentary, you really need to. It is a fantastic kind of historical perspective about bed rest. David Grimes was one of my mentors and one of my wife's mentors, and is a fantastic doctor. And he co-authored this with actually one of the residents from Chapel Hill, Christina McCall. But it was published in 2013 in the same journal as that first study of 650 women where you found the potential for harm from this practice. And it goes through the whole paradigm of, as providers, we want to do good things. We want our patients to have good outcomes. And so I talked about how, you're spotting, you're bleeding in the first trimester, bed rest, and your blood pressures are creeping up at 32 weeks. Stop working. Don't do anything, bed rest, or watch Netflix, or whatever you want to do. Twins, triplets. Oh my gosh, every time you see them walking around, get off your feet, what are you doing? Putting all that pressure on the cervix. So people have traditionally, for decades, told patients to do these things. So why might our intuition be incorrect? If you think about what triggers preterm birth, some of the different biologic pathways, whether it's a pro-inflammatory state, infections, when you're on bed rest, you're sort of that's sort of a pro-inflammatory state because your blood's not moving very much. You're more prone to thromboembolic phenomenon. Muscle bone loss wastes away within a few days to a degree that your immune system is suppressed. So it makes it harder to fight infections, and you're more prone to these other issues, financial insecurity, depression. You're isolated. Everybody else is living their life, and you're told that you have to stay in the bed because moving will hurt your child. The anxiety that must provoke has got to be profound. There's a Cochrane review. I believe they've updated it since 2015. But when you look at the studies on activity restriction, admittedly, there's not a lot of well-designed trials because they're hard to design. But there's no evidence supporting bed rest to prevent preterm birth. ACOG, like we said, sometimes they don't put out very strong statements. But if you actually look at the one for this one, although bed rest has been recommended to prevent preterm delivery, this is not shown to be effective and should not be routinely recommended. The potential harms and negative effects should not be underestimated. It's a pretty strong statement from one of our societies. So it's something to think about because we want to take good care of our patients, obviously. I'm just not sure that strategy is the best. I'm going to transition to a topic that unfortunately does not have as much robust data as we would want, but twins and triplets, they get short cervixes all the time. And so that's a problem because they're already at baseline risk for preterm birth because of their multiple gestation. And then we're looking at a short cervix. It's on their anatomy scan. The sonographer walks in the room. She goes, abdominally, it doesn't look good. And they did a transvaginal cervical length, and it's, 18 millimeters. It's an IVF pregnancy. It's their one shot, and they want you to help them. So what do we do with that scenario? This was it's 20 years old now, but it's a meta-analysis of the data we have that are in reasonable studies, mostly RCTs, about whether cerclage prevents preterm birth in women with a short cervix. And they looked in this meta-analysis at singletons and in multiples. Cerclage was associated with a doubling in this study, or in this meta-analysis, of the incidence of preterm birth compared to controls. And I remember when this got published, I'll keep hearkening back to my own time in training, but towards the beginning of my residency, and if you even thought about stitching a twin or triplet at Chapel Hill, you were persona non grata. Because my attendings would wave this thing and be like, you're going to double her risk for preterm birth, you're crazy. Interestingly, the same authors, using the same data, reanalyzed it with more sophisticated statistical techniques 10 years later. Medicine makes me laugh, it really does, especially this part of it. But when they looked at this, and you see Dr. Bergella's name again on this article, same data, just different statistics. What's shocking when you look at this, and again, there's studies, but I'm talking about reasonably well done RCTs. There was only 50 twins that they could look at in all the data prior to 2015. They didn't see harm, but they didn't see benefit. So they analyzed the same 49 patients and came to the determination that we weren't really hurting people, but we weren't really helping them either. And so their conclusion was we should not be using a cerclage in twins with a short cervix. There are some retrospective studies, so these aren't RCTs, that have been recently published regarding twins in a short cervix. This is one where they had 40 consecutive twins, short cervix, mid-pregnancy, got cerclages, and then 40 controls, similar cervical lengths and gestational age, that did not get a cerclage. Again, retrospective cohort study, not a randomized control trial. And in this study, there was a benefit, about a decrease of 50% in the rate of preterm birth. And there's been some other retrospective cohort studies, not RCTs, with twins in a short cervix that found relatively similar results. They illustrate the need that we need more quality randomized control trials. And the problem with that is not many people are excited to be randomized into a trial like this. It's a very difficult study to do. Patients are, they're smart. They can look up and say, well, you got cerclages and vaginal progesterone, and I could be in a group that gets neither. And so this is a very difficult study to do, but we need more of these studies. This is a very unfortunate area of my field where we just don't have a lot of good quality data to make a good evidence-based recommendation. What about vaginal progesterone? This is a meta-analysis that was also performed looking at singletons and multiples. Doesn't seem to be as promising in multiples as singletons, but there was, in the meta-analysis, a non-significant reduction when you use vaginal progesterone to prevent preterm birth in twins. There was some significant reduction in neonatal morbidity and mortality, but not enough for us to make really good firm conclusions that this is effective. And that makes sense because the pathways that a twin and triplet get to a preterm birth are almost certainly very different than a singleton, and sometimes they overlap. So we need more RCTs to also look into this. Pessaries were kind of the hot thing about 10 years ago. And I want to present two studies that I think were published in the exact same same edition of the American Journal of OBGYN in 2016. They were both really well done studies. They were multi-center, randomized control trials. This one in particular was done in Spain. I had 137 twins with a short cervix randomized to pessary or expectant management. And the outcome that they were interested in was preterm birth less than 34 weeks. This is the pessary they used. I'd have to get my wife to help me figure out where one of those is hiding at Memorial Hospital in Savannah, but the Arabin pessary was the one that was used in this study. And this is their results. So the pessary group had significantly lower preterm bursts, less than 34 weeks, compared to controls with a confidence interval that did not cross 1, relative risk of 0.41. And when you look at the gestational age at delivery, because I think that makes it more real when you try to explain this study, it gets you about 2 extra weeks. So if you're in the expectant group, you delivered around 33. If you're in the pessary group with your short cervix, you got a little bit more time, approximately or just over 2 weeks. But in the same edition, they did this for a reason. This was another well-done RCT using the exact same pessary in twins with a short cervix, pessary control, and they did not find a difference in preterm birth. I think there's hope. I know that this part of the talk is a little bit less optimistic, but we need to figure out what subgroups. I'm certain or near certain that there is a subgroup. We all have seen these patients do well, whether that's anecdote, but we need evidence-based guidelines and principles to build off that so that we know we're doing the right thing. So we need more RCTs looking at twins with and without a preterm birth in their history, a short cervix. Perhaps there's a critical measurement where progesterone is effective or cerclage is effective. And we need RCTs, and some of them are ongoing, to be fair. If I had enough time, I'd show you some of the ones that are going on right now that I think are promising, but these are tedious studies. They're costly studies. They often take years to complete because you need enough numbers to power it so that we have a study where we really got some meat we can get into, and we know we can use that to help our patients. So there's lots of studies going on to address this. But as of right now, it is sort of an area where my colleagues and I will sit there and kind of talk to each other, and you just have to use your best clinical judgment. There's still a place for that. I tell my learners that how we, I think, should practice is grounded on principles of evidence-based medicine, but let's be honest, the fun part is the art of medicine, and sometimes you have to use your best clinical judgment. But it'd be nice if we had better studies on this issue. Almost done, almost to lunch. These next 3 slides are just the summaries, key points, if you will. So cervical link screening, everyone who has a preterm birth or a mid-pregnancy loss, I think, should get this. I didn't address prophylactic cerclages because it's sort of a different topic, but if you have that person you know has a strong history that suggests they have cervical insufficiency, obviously they're going to go into a category where they're going to get offered a prophylactic cerclage. But for those patients who either decline that or have had just a 28-week preterm birth, all of those patients should get cervical link screening. 16 to 24 weeks has been the standard approach biweekly or every week, depending on your level of concern and what the cervix is actually measuring, is a reasonable way to do that. Or you could do universal screening. ACOG and SMFM says it's reasonable. So how you do that in your practice, I think, is up to you and the patient population you serve, but I think there's a role to continue to discuss it. There's plenty of cost-effective studies looking at this, but I think it's a reasonable thing to consider depending on the population you're serving. If you have a short cervix, and I put less than 24, I know that viability age is getting squeaked up a little bit by our neonatology friends, so perhaps it's less than 23 or 22, it's your comfort level, but if they have a history of a spontaneous preterm birth, cerclage tends to be the first line therapy. If they decline that, or perhaps when you do a physical exam on that person with a short cervix and it's flush with the vagina back there and you don't think they're a good candidate for a cerclage, vaginal progesterone is a reasonable alternative for those patients. And then you kind of flip it for a short cervix if you do not have a history of a preterm birth. So vaginal progesterone, for most patients with a short cervix and no prior history of a preterm birth, probably should be considered first line, with the caveat that some of us consider the extremely short cervixes, less than 10 millimeters, as sort of lumping them into sort of the, should we offer them more of like a rescue cerclage? But for those patients who are just 22 millimeters with some funneling, probably vaginal progesterone, based on the data we have, is first line. And then in our office, and every practice is probably a little bit different, is we'll continue to follow them, especially if they're remote from viability. And if that cerclage continues to shorten despite the vaginal progesterone, that's where we might consider doing a cerclage. With the caveat is, the caveat that there's not great data, but in our best clinical judgment, if they're failing that treatment, at least we have something else to offer that's of relatively low risk. Short cervix in twins and triplets, clinical judgment. I think vaginal progesterone is a reasonably low-risk intervention that may have some potential benefit based on the available data. Cerclage, pessary use, based on your clinical judgment. We'll see twins that show up, 8 millimeter cervix at 19 weeks. It's hard to do nothing. To be fair, the bed rest argument is you probably shouldn't. We don't really have any strong data for that either. I would think long and hard about significant activity restriction. Some modification of activity may be indicated based on that person's unique clinical circumstance, but as a general rule, significant activity restriction for a short cervix, or in my opinion, for any obstetric complication, is really a practice that we should abandon. And with that, I'll give you a nice little view of Savannah, and happy to entertain any questions you have. Well, that's Dr. Sullivan. Hello,
Doctor.
sir.
Hello, good to see you. Great talk. Thank you for that. You mentioned if you adopt universal screening that some places do abdominal, some places do vaginal. Would you give us kind of the pros and cons of that, like ease versus quality of imaging, that type of thing?
Sure. So obviously, the transabdominal cervical links are sometimes difficult depending on the habitus of patients. And so there we see, as I'm sure you do, Dr. Sullivan, some very large women that come through your high-risk office, as I do. For those people who we really can't get an assessment at all, we usually, especially if we have some concern, we'll say, hey, would you consent to this? There are good studies correlating using a transabdominal measurement with trans-cervical measurements, or transvaginal measurements, excuse me, and they show reasonably good correlation. Transabdominal is certainly not as accurate, there's no question. So I think if you do a transabdominal approach, you need to have a relatively low threshold to then offer or recommend a transvaginal exam if you're worried. The cost and, the logistics is complicated because, we'll see in our office, we'll see 80 to 100 people for ultrasounds a day. And granted, not all of them are in the window where you would offer screening, but a large percentage of them are. And to have enough probes that are, our sonographers are all great, so I'm not worried about their training, but to have them cleaned, back in, the queue to be used again, the throughput would not be very efficient. So there are some logistics there that should be considered, but Dr. Woodham.
Yeah, great talk. Thank you. Quick question, it's two parts. First part, to piggyback off the last question, is do you all have a cutoff for the transabdominal length that you like to use to then say, you know what, we're going to have to do a transvaginal? I'll let you answer that, then I'll ask you a second question.
Yeah, it's usually anything under 30, the sonographers will flag, or if maybe perhaps it's not, but it looks like there's some funneling, something, then they'll come to us, and our threshold is generally pretty low to offer the transvaginal exam.
Okay. And the second question is, let's talk about patients who come in past 24 weeks that come to OBED, contracting. I know some people like to do transvaginal cervical links on them. What's your opinion about that? Do y'all utilize that to decide who to keep or not to keep, or do you still do the old school FFN like some of us still do?
Actually, I do the old school physical exam.
It's great. I love it. Love it.
No shade there, Dr. Woodham.
Yeah.
No, I think the utility of doing a transvaginal cervical length after the point where you would do these interventions is a very low utility. So even after you do a cerclage, there's an argument to be made that you shouldn't do anymore. I will say we will do them as a role to who should get some prophylactic betamethasone perhaps as they approach viability. So if you throw that cerclage in and you see them at 23 weeks after you've done the cerclage, and it's a pretty good cervical length, they're asymptomatic, maybe you hold tight. But if they come back and they're funneling through the stitch, maybe they don't have exposed membranes, but it's 10 millimeters, I would use that as a metric to offer prophylactic betamethasone at least you have that. So I think there is some utility, although to be fair, it is argued that probably after you've got a cerclage, that's not always necessary.
Thank you.
Yes, ma'am, thank you.
Hey, Dr. Baker.
Hey.
Michelle Gainty from Savannah. We know each other. As someone, I have a question about bed rest. As someone who has a personal history of being admitted to your hospital for many weeks, this time for preeclampsia, but has your practice changed on managing the inpatients with bed rest? I personally would do a walk around your hallway once a day, but otherwise I was kind of kept in bed.
Yes, and
Have
I'm
you
sorry about
changed
that. I was one of your jailers, so I apologize. It's interesting you asked that question, and the residents who round with me will see me do it, but I try to remember to tell these patients, I know you're here with your ruptured membranes at 28 weeks or your severe preeclampsia we're expectantly managing, but I try to remember to tell them bed rest is not part of the reason you're here, but that's the only thing there is to do. So we try to encourage them to walk. I say, I want to see you in the halls. When I'm rounding, it better not just be in your room. I want to see and talk to you in the hallway. I don't want you to run outside, but please do some laps. We have like a sort of an escape room now on our, yeah, you didn't have it then, but sorry. But there's a TV in there, there's some games. It's a place for some of the poor women who are stuck there can commiserate or meet with their families. And just try to have some normalcy back, because that's the biggest issue we see when we have those women in the hospital is just they're so isolated. A lot of them are very depressed. It is an awful thing to commit someone to hospitalization until they give birth. And so we do our best. It's not perfect. I'm trying to get my hospital administrators to inject some more funding into having some other spaces where those women can go without jeopardizing their health by letting them leave the hospital, of course. But it's a problem. But yes, that's you know, and we're worried about. We've had many patients on our service have thromboembolic problems. So then you're like trying to put them. Should I put this person on Lovenox? They're not getting out of bed. But then if they get a stat C-section, the anesthesiologist won't put an epidural. And then I got to put this lady who's 400 pounds to sleep, and she's got a bad airway. And it's interventions beget interventions. And so I like to see them walking, and I encourage them to do so.
There was a couple times I escaped the floor and didn't tell anyone.
I know. I knew about it. I wasn't going to tattle.